Welcome back to the Band-Aid Man OC, your source for all things EMT, EMR, and sports medicine. I'm your man, Eric Johnson, aka the Band-Aid Man OC. Today, we're going to be going over Chapter 32 on our EMT textbook, and we're going to be talking specifically about obstetrics and gynecological emergencies. So today, we're going to be talking all about our female patient constituents. Now, before we get started and really get into the nuts and bolts of this, I do want to put out a very brief warning for those of you that may be triggered by some of the stuff we're going to be talking about. Now, I'm not talking specifically about childbirth. I think that that's something that most of my students, I should say all of my EMT students, would be able to take with maturity. But I do know that these videos may be watched by a younger audience. So I want to let you know that all of the pictures that were in the original slideshow depicting actual childbirth have been removed so that this video can stay up for you, but there are animations or drawings of childbirth in its various stages. We will also be talking about some topics that are very sensitive. Specifically, we'll be talking about the treatment of female patients as it relates to sexual assault. So I am very aware that this is a very sensitive subject for some of my viewers, so I wanted to let you guys all know before we got started that that will be coming up, and I will do my very best to put in a second reminder about the potentially triggering material that we're going to be talking about. But as it stands for EMTs and for EMS in general, whether you're going to be a first responder, an EMT, a paramedic, or work in medicine, these are all very real calls that we may be asked to go on if we work in pre-hospital medicine. So it's important to understand that this is something that we absolutely must talk about. But without much further ado, I say that we jump in. Today, we're going to be going over a litany of topics. This is actually going to be a fairly long video, so if you are just sitting down and you didn't look at how long the video actually is, strap in. We're looking at least an hour and a half. So what are we talking about today? Well, we're going to start with anatomy and physiology. Understanding the anatomy and physiology of our female patients is going to help us better serve them so that we can understand the areas that are of most concern, especially as it relates to childbirth, because childbirth, while a very natural process, can be very dangerous if left completely alone. And we want to really focus on the areas that we should be focusing on as EMTs. Next, we'll be talking about the physiologic changes that occur during pregnancy to the mother. We'll talk about the process of labor and delivery, as well as patient assessment. We're going to touch on the differences between a normal childbirth and the neonatal patient. And remember, neonate is a brand new baby between the ages of 0, so no days, to 28 to 30 days. And a lot of publications are a bit different on that, but we'll go with the generalized term of 30 days. And then we'll talk about how we can care for the baby after delivery, as well as care for mom. We'll also be talking about complications from childbirth, whether it be before, during, or after the actual childbirth procedure. And then finally, we'll be finishing up with gynecological emergencies, and that's where we'll be getting into some of that more triggering content that I talked about before. But don't worry, I'll be sure to give you a heads up. Now, before we get started, as I said before, we are going to be talking about reproductive organs. If this is something that you are uncomfortable discussing or uncomfortable watching, I would recommend perhaps checking out the PowerPoint that's listed elsewhere, or perhaps doing some research on your own. But we are going to be talking about that today, and I just thought that it would be good to make sure that everyone was very aware. But without much further ado, let's get started. So to understand our patient and to understand exactly what type of complications we can encounter, as well as things that we would normally expect to see in childbirth and in regards to gynecological emergencies, we need to understand the anatomy and physiology of female reproductive organs. Now, the outer genitalia is comprised of the labia, the perineum or perineum, however you'd like to say it, and the mons pubis. We also have internal aspects of the genitalia. The vagina itself is comprised of the area that is most usually associated with childbirth. It is a smooth muscle that is easily able to pass large amounts of tissue, especially during childbirth, with its own musculature. It's also going to be where we find different aspects of anatomy like the ovaries and the fallopian tubes. Now, the ovaries and the fallopian tubes are specifically for the purposes of reproduction. The ovaries are what produce the ova, and for those of you that have taken some type of anatomy and physiology class, you already know where we're going with this. But for those that haven't, let's talk a little bit about this. Ovaries produce ova, which are sometimes referred to as eggs, and these are going to be the female component to childbirth. The male will provide sperm, and the sperm will fertilize the ova. The fallopian tubes is where that fertilization occurs. Now, the fallopian tubes themselves are really only there for the specific purpose of fertilization. We don't have very much involvement after the initial fertilization occurs because the egg, once it is officially fertilized and it's a viable pregnancy, will move and begin to develop outside of there. However, pregnancies that occur outside of the fallopian tubes are not going to be viable for the specific fact that it is not conducive to a livable environment. As a matter of fact, any pregnancy that occurs outside of the fallopian tubes is known as ectopic. Ectopic pregnancies are very dangerous. They are not viable pregnancies, and they will very rapidly kill our patient, and by our patient, I mean our mom, because the pregnancy itself is not valid. Now, we do get calls for ectopic pregnancies and ectopic pregnancy complications, but we'll be talking about that a little bit later when we get into complications of childbirth. Then we have the uterus. Now, the uterus is really where the majority of development and growth occurs. And the uterus, in my opinion, is the most important aspect of child development as we deal with the fetus and the growing, nearly neonatal baby. Now, the uterus itself is also muscular, just like the vaginal cavity, and it is a hollow organ that is located along the midline of the female lower abdominal quadrants. It is the intended site for fertilized eggs to be implanted and then developed into the fetus. So it goes from the fallopian tube, embeds in the uterus, and then begins the process of development. The uterus itself is a pretty amazing muscle. It's able to stretch and grow as large as needed for the fetus to appropriately develop, and as soon as it's done, it will shrink back down to size and then do it again if there are more babies coming along. And as we've already known, it is possible for female patients to have multiple babies at one time, twins, triplets, quadruplets, so on and so forth, and then beyond that, they can go and have multiple babies in multiple pregnancies. So the uterus itself is a very hard-working set of musculature, and it's unique, obviously, to female patients. What separates the uterus from the actual birth canal is a muscular ring known as the cervix. Now, the cervix itself is also a pretty special device, but the best way to think of it as we are dealing with female anatomy is almost like a gate. And it's a gateway from the uterus to the vagina, and specifically where the baby will be pushed and eventually birthed. And it operates as a somewhat of a gatekeeper. We don't want the baby to come out too early because they won't be fully developed. And we certainly don't want the baby to come out because of something like a bowel movement or because of an upset stomach or something of that nature, or even something involuntary like a sneeze. So the cervix stands to prevent the baby from falling out, because that would definitely be bad. Moving forward, we have the female genitalia broken down here in this diagram. I'm certain that this is nothing new for my students. We've seen these in health classes and in anatomy and physiology before, but this is a really good way for you to take a look at all the different aspects of the female anatomy as it lays for reproductive purposes. And the most important aspect of that is understanding what we're looking at as pre-hospital care providers. Now, the female reproductive cycle is a normal monthly, usually monthly cycle known as the menstrual cycle or menstruation. Menstruation itself is stimulated by hormones estrogen and progesterone. And what is occurring is that the ovaries are releasing the ovum or the ova, the eggs, and the uterus walls are thickening. If there is no fertilization of these eggs, then in that period, the uterine wall will be expelled, and there will be a period of 3 to 5 days where bleeding occurs. And I want to be specific. When I say that there is a period of this occurring, I mean that there's a specific amount of time. Many people refer to a menstrual cycle as a period, but as medical professionals, it is important for us to understand that we need to kind of dive between the medical aspect of things and the regular civilian aspect of things. So I would typically recommend that if we're talking about a menstrual cycle, we specifically state the menstrual cycle is what's occurring. If our patient is a little confused as to what that is, then we can go ahead and we can move on to the menstrual cycle is also commonly referred to as a period. Are you having your period? Have you had that? When was the last time? Can you tell me more about it? These are all important aspects for us to understand, because if we don't get this information, it's very difficult for us to understand if that patient is pregnant, if they have the ability to be pregnant, and if that is out of whack, if they may already be pregnant. So just a couple things to think about. And before we get much further, I want you all to think about this for a moment. This is a very private aspect of patients' personal health. It is not something that most people are particularly confident or comfortable talking about in large groups, and certainly not with a stranger that they just met because they dialed 911. If you feel like it is a pertinent question, we can always wait to ask that until it's a bit more private. And especially with our younger patients, we may want to refrain from asking that until we have a little bit of alone time with them to make sure that they feel comfortable. Also, this is a great opportunity to bring in a partner that is also female if you have a partner that's female. If you have two males, this is going to be something that eventually will need to be broached, especially in cases of abdominal pain or of some type of vaginal bleeding. But it's something that should be very targeted in the way that we ask. If we are not targeted in the way that we ask, head pain and menstrual cycles rarely have much to do with each other, so keep that in mind. Now, fertilization, as we've talked about, the sperm reaches the ovum becomes an embryo, implants itself in the uterus, and then the fetal stage begins. And we've talked about this because the fertilization process is very brief. It doesn't take very much time. What does take time is development of the fetus. That in itself is a 9-month process. Now, during that process, there are some pretty significant physiologic changes that occur in our female patient. Now, a 9-month pregnancy is what we're looking for. It's not always going to be exactly 9 months. It's not always going to be exactly 40 weeks. We can see patients that are a little overdue at 41 weeks, or a little early or premature at 35, 36, 37 weeks, so on and so forth, with little to no issues with the fetus. However, we do have a bit of a cutoff. And medically, we usually dictate that at 20 weeks, the fetus is now theoretically probable as a surviving individual baby. That baby can be nursed back to health, even though if born at 20 weeks, it would be severely premature and would likely have some type of developmental issues. However, before that 20-week mark, we really don't consider the fetus to be officially viable for life. Now, that's not a political statement. That's not me trying to say anything about the survivability of babies. That's just scientific fact, and that's the way that we operate. 20 weeks is very, very early. That's only half of the developmental cycle, and even though at a very early stage your mother may be showing, we want to remember and understand that there are certain cutoffs. However, that's really not something that we need to bring up to the patient. If they're pregnant, whether they state it or it's very obvious, we'll treat them as if they are pregnant, and we have two patients that we're taking care of. Now, how do we refer to this fetal individual, this patient? Well, we will call this patient our fetus, but in the presence of our patient, we'll call them the baby. But what is this really developing from? Well, it starts with an organ known as the placenta. The placenta is an organ that is only present during pregnancy. It is maternal and fetal tissue, so tissues made up of both the mother and the baby, and this is what helps allow for the exchange of oxygen and nutrients between mother and baby. The umbilical cord also assists in the transfer of specific materials between mother and baby, but really what it's doing is it's operating as a blood superhighway that allows for oxygenated blood to be delivered to the baby and deoxygenated blood to be delivered away from the baby to be expelled as waste. The umbilical cord is something that is there very early on and something that will actually be expelled when the baby is born, and is something that we really want to take special notice of because it can provide for not only for the delivery of oxygen and blood, but it can also cause there to be specific types of complications in childbirth, such as a cord that is wrapped around the fetus's neck. We know that we call that nuchal cord, but that's something that we need to discuss specifically on how to relieve if we find it. And then finally, we have the amniotic sac. Just like our heart and our brain, this fetus has a very thin protective membrane that allows for fluid to be introduced where the fetus can float. It operates as a cushion and it helps maintain fetal body temperature. It has a lot of other processes as well, but the amniotic sac, just like the umbilical cord and the placenta, will be part of the delivery. And we'll talk about that in just a little bit. Now you can see in this diagram everything that we've been talking about, the amniotic sac, the umbilical cord, the placenta, and what you can really see from all this is that it's all integral in the development of our baby. I'll give you guys an opportunity to pause here, take a look, understand the anatomy as it sits in our female patients, especially with that fetus as it's growing. But you need to understand that being able to identify the umbilical cord and the amniotic sac will be crucial in your ability to provide effective care in emergency childbirth. And then your ability to understand that the placenta, while it does need to be delivered, is not something that we wait around on scene for, will also be beneficial in your ability to determine appropriate levels of patient care. Moving forward. Physiologic changes in pregnancy are not just going to affect the reproductive organs. We're also looking at systemic changes throughout the entire body. The cardiovascular system is changed by noting the increased blood volume, as well as the increase in cardiac output and heart rate. In the respiratory system, we see an increased demand for oxygen and an increased consumption of that oxygen. In the gastrointestinal system, we'll start to see some signs and symptoms of pregnancy, such as nausea and vomiting. Many people refer to this as morning sickness, as it's very common that it strikes as the patient wakes up, as well as slow digestion. We'll also see changes in the levels of hormones. The hormones in the body are changing because not only is the mother developing all these systems and helping develop the fetal tissue, but the baby also has a demand for hormones as well. These changes in hormones will also have a very specific effect on the ligaments in the female's body, which is good. It will allow them to effectively and more safely pass the baby during childbirth than before, but it does open them up to more vulnerability for injury because ligaments, as we've already discussed, are throughout our body. Now, there's other considerations that we really want to take in, as well as try to prepare for as we're providing care. There's additional weight. That additional weight will affect posture. It will lead to back pain and balance issues, as well as put a lot of pressure and weight on both the fetus and the mother, depending on their position if they're laying down, as well as other issues as it relates to pre-existing medical conditions. Pregnancy overall is considered to be a massive, massive change to the patient, and it's something that is taken into consideration in everything that we do. There are different orders and different recommendations for a patient if they're pregnant in virtually every aspect of medicine, whether it be physical care or some type of care as it relates to medications. Really, everything changes once we know that our patient is pregnant. Now, what we can see here is a picture of a patient that is fairly far along in their pregnancy. Remember, just because a patient isn't showing any visible, and I'm putting up air quotes here, baby bump, it doesn't mean that they are not further along. And it's something that we should take at the patient's own, at their own word. If they say that they're pregnant, I will never argue with a patient. I will never say, there's no way that you're pregnant. My answer is always, okay, how far along are you? Have you started any prenatal care? Are you feeling any kind of discomfort? Do you feel like the baby's in any distress? These are all very normal questions to ask a pregnant patient, and we'll get to that when we start talking about assessment. Now, as we discussed before, there's a lot of additional weight that is exerted on the mother as a result of of not just childbirth, but of the actual process of becoming pregnant and allowing that fetal tissue to develop. How much weight, you ask? Well, 20 to 24 pounds. And if that doesn't sound like a lot, go ahead and take off your backpack, load all of your books into it, and then wear it on your front for 9 months. Yeah, it's a fair amount of weight, and it definitely has a very strong chance of becoming a physiological challenge for our patient. What are those challenges that we're talking about? Well, it can compress the inferior vena cava, which will cause there to be restricted blood flow in the heart, which will cause cardiac output decreases, and then dizziness and drops in blood pressure. There's also physiological problems with laying supine, and we really want to encourage our pregnant patients to lay on their left side. That will allow for better blood flow through the heart, and it will allow us to continue to assess them in a way that does not cause additional stress on the mother and on the fetus. Now, as we're doing our PowerPoints here, there are plenty of these slides that come up about the development of the fetus and how it affects other body systems. I think that we've gone over in some pretty general terms what can change, but now it's an opportunity for you. What other body systems will be changed, and what other types of physiologic changes can we expect to see from pregnancy? Go ahead and put those in the comments below, and I'll be sure to get right back to you to let you know what my thoughts are. Now we're getting to the meat and potatoes, the good part, the big show, labor and delivery. We're going to start catching babies here, folks. This is the most exciting part of the whole thing. Now, as we are looking at the stages of labor and labor itself, we need to understand that there are obviously separate stages. The first stage begins with regular contractions and then ends when the cervix is fully dilated. And we'll talk about that more in a little bit, but really those are the individual aspects that will determine for the seasoned EMT whether or not it is time to stay and play or load and go. More often than not, if you're at the point where regular contractions are occurring or the cervix is fully dilated, it's time to sit down, stay and play, and deliver this baby. The second stage occurs when the baby enters the birth canal and is born, and then the third stage is when the baby has already been born and the afterbirth is delivered. In the first stage, we're going to be looking at two things in particular that will indicate that the mother is ready to deliver the baby. One of the very first things that we can start doing is recording and timing contractions. Now, recording and timing contractions is very important to understand in what we're actually doing. We need to record two things simultaneously, but don't worry, we can stop the timer and then start a second timer, so it won't be too difficult. The first thing that we want to time is the amount of time the contraction lasts. Was it a minute, 2 minutes, 30 seconds, 15 seconds, 5 seconds? What was it? Then, when the contraction ends, we want to record how much time it takes for the next set of contractions to occur. And we'll talk about what we're looking for specifically in the next slide. Now, there are abnormal types of contractions. One of the most common is Braxton Hicks. Braxton Hicks contractions are irregular, non-sustained contractions that are not indicative of impending delivery. We will only understand that these are Braxton Hicks based off of our own timing, so it's important to understand that we need to look at anywhere from between 2 to 3 of these false contractions before we can determine if they are true or if they're Braxton Hicks. That in and of itself may take some time, and while we're doing that, we can conduct other aspects of our patient assessment. This is still a good opportunity for us to consider initiating transport, but remember, the back of an ambulance is usually pretty small and cramped. Most of the space is made use by different pieces of equipment or storage. It's not really a great place for us to deliver a baby. So unless you're real concerned about the overall presentation of mom, the mother, or if you're looking at a very long transport to the hospital, we may want to set up to stay in play, even if it is Braxton Hicks contractions to start. Next, we're going to see lightning. The fetus will move from the high end of the abdomen towards the birth canal, and this is where the baby somewhat drops in the uterus itself. They ride much lower if the mother is standing up or seated. Now, contractions from the uterus will produce normal labor pains, but those contractions may not be correct or true. And by correct or true, I mean it may not indicate that the baby is about to be born. So understand, mothers, especially in high-risk pregnancies, first-time pregnancies, or in pregnancies of multiple babies, may have contractions that are nowhere near their due date. So understand that before you move forward. The characteristics of labor pains are important to understand. The time and duration and frequency are what we've already talked about. We want to know how long the contraction lasted and how often they're occurring. If we get to a point where they last 30 seconds to a minute and are spaced out by about 2 to 3 minutes, the delivery of the baby is most likely imminent. We should also most likely see that the cervix is dilated. We may also see other signs and symptoms, but these are the big ones. We also want to talk about the amniotic sac. Now, many times in Hollywood, there is a moment where a woman that is pregnant says, "I can't believe it, my water just broke," or they have that comical moment of, "Oh my goodness, did you pee all over yourself?" "No, my water just broke." "Oh man." Cue up the music, everybody's running around like they got their hair on fire, and it's pandemonium. What is actually happening is that the amniotic sac is breaking. Breakage of the amniotic sac is a normal part of delivery. As a matter of fact, we really look for that and expect to see it in a healthy delivery. However, if the amniotic sac doesn't break, or if when it breaks, we see that there is a brownish, green-yellow material, that is a problem. And we'll talk about those in a little bit, but let's talk about meconium. Meconium is basically waste from the fetus, and it is usually only expelled in that manner if the fetus is under extreme amounts of distress. They are dealing with something that is really problematic. It could be anything from the umbilical cord being wrapped around their neck to some type of developmental delay or issue to stress on the mother, whether that be physical, emotional, whatever the case may be. So if we start to see that brown, greenish, yellow colored staining, meconium staining is an indication that the baby will not be healthy on delivery, and we need to anticipate doing some type of aggressive patient care or resuscitation. Moving forward. In the different stages, we can see that the baby will most likely, and we prefer to see it, deliver with the head first, face down. Hey, face down is great. That's what we're looking for, but face up, still not a huge deal. It's called a facement, or as one doctor I worked with said, sunny side up. But sunny side up or a facement is not nearly as big of a deal as it is for other providers, because, of course, we are working in a space that is not designed for childbirth. We are working in an area that is not designed to welcome babies into a clean, aseptic environment. Okay? So we'll go ahead and I'll let you pause here if you want to take a look at this diagram real quick, but we're going to move on in the video. In the second stage is where we see the full dilation of the cervix and the contractions become more frequent. This is the aspect where labor pain becomes most severe, and the mother will feel an urge to push or move their bowels. At this point, this is where we need to make a critical decision. Do we stay in play or load and go? If you are looking at your patient, the contractions are anywhere from 30 seconds to a minute long and anywhere from 2 to 3 minutes apart or less, so more frequent. We see that the cervix is fully dilated, or we start to see the head protruding from the vaginal cavity, it's time to sit down, stay in play, set up, and deliver this baby. If we're getting any of those things and we're not seeing full dilation of the cervix, or we're not seeing any kind of presentation of the head or another limb, we can go ahead and make the determination on do we want to stay in play or load and go based on transport time. If the hospital's 5 minutes away down the street, I'd say it's probably a good opportunity for you to go ahead and load and go. If the patient is 35, 40 an hour away from the hospital or more, yeah, we may need to go ahead and set up shop right there and allow her to begin the process of childbirth. Because once we start transport, the only thing that we can do to effectively allow for childbirth, we really probably need to pull over, and that's going to delay our transport by a fair amount. Okay, moving forward. As you can see here in this diagram, the second stage is fully in play and the baby is being birthed. And you can see that this is a normal birthing position. The baby is face down, head first, and we'll talk about the way that the baby will actually come out. And it is important for me to note here, this is something that I've done in the field 3 times, and I have assisted with the doctors in the hospital 5 times. So I'm by no means an expert. I've only done this a handful of times, and really, I would say that I'm kind of on the underside of average after working in the field for 12 years. But childbirth, especially childbirth in the field, is not something that happens very often. It's usually a pretty happy occasion, and as long as the baby is healthy, that's something that we find cause for celebration. It's not uncommon to see in the newspaper that a local fire crew or a local ambulance crew, set of EMTs and paramedics, were able to successfully deliver a patient in less than austere conditions. Side of the road, in the backseat of a car, back of the ambulance, in the middle of the mall, wherever the case may be. So we want to make sure that we understand that as long as these things are present, face down, head first, shoulders delivering second, one by the other, these are going to be our average childbirth situations, and that's what we're looking for. In the third stage, the baby has been born. At this point, we have care that we need to provide to both mom and baby, baby being the specific focus as long as mom is healthy, and we will anticipate that after we get all of that going and the baby is healthy, we can begin transport. There is a third aspect that we need to be aware of. Contractions will resume to deliver the placenta. The placenta can take up to a half an hour or even more to deliver, so we don't want to stay on scene to wait for the placenta, also known as the afterbirth, to be delivered. We want to go ahead and prioritize getting both mom and baby to the hospital and focusing on that process. If the placenta is delivered while we're driving to the hospital, that's totally fine, and we'll go ahead and place that in the specific bag that's provided in our kit, but we don't want to wait on scene for that process to occur. Okay. Now, I don't think that this question has much room for answer. Why is childbirth such an exhausting ordeal for the mother? There's a lot of muscle usage. It is a lot of effort and a lot of work. Make no mistake, the childbirth that you see in the movies is very close to the kind of effort that you see, but you're only seeing a very small 30-second snippet. Childbirth can be a very long, arduous process, but if we are prepared for what is occurring and what we are looking for, it can be a very fast and, granted, very rewarding experience, not just for the parents, but also for the providers. Now, our assessment of the patient is going to be important, and it is super important right now, right here, at this moment, to remind you, when we have a pregnant patient, we have 2 patients. We've got mom, and then we've got baby. If baby is not healthy, mom will know. If mom is not healthy, the baby will suffer. So we really need to focus on both. And we need to understand that at certain points, one will end up being the main focus of our care and assessment, and then at other times, they will not be that main focus of care and assessment. And it also really depends on the presentation of both patients at any one given time. Okay. So, as we're doing our assessment, we need to try to focus on imminent delivery. We want to know name, age, and their expected due date. We also want to ask some questions that will lead us to understand and to infer what type of pregnancy we are looking at. Is this a first pregnancy, or is this your second, third, fourth, fifth pregnancy? Are you seeing a doctor about your pregnancy? Are you receiving what's known as prenatal care? When did your labor pains start? And specifically, what do you determine as labor pains? Being uncomfortable and having labor pains are two separate aspects of childbirth, especially imminent childbirth. So we need to really be very clear on that. But understand that if the signs and symptoms are consistent with imminent childbirth, it's time to stop asking questions and we need to focus on delivering the baby. We also want to ask the patient, do you have any urge to push? Or do you feel like you need to move your bowels? Yes, I know. We want to ask them, do you feel like you need to poop? The reason why, that baby is usually falling into the birth canal. They've dropped in the uterus and they are being prepared to move into the birth canal, and that puts a lot of pressure on the rectum and on all of the aspects of the rectal cavity. We also want to look for specific signs like crowning. We can also feel for uterine contractions by placing our hand directly over the pubis, and we can also take vital signs. We definitely want to get vital signs taken as early as possible. So, what would indicate to us that this is not going to be an average childbirth, or that the inbound neonate, the brand new baby, may need resuscitation? Well, a couple things. They don't have any kind of prenatal care. The delivery is premature, and we're talking anything outside of their, before their expected delivery date. The labor itself is induced by trauma, whether that be physical, mental, whatever. Or if the mother is expecting multiple births. And I'm going to add a couple more here. Some things that I would be concerned about. Previous instances of some type of birthing issue, whether it be miscarriages or some other type of developmental issue, and the use of drugs and alcohol. Okay, as we see here, those are indicated, but we really want to understand what those complications are. So these pregnancy problems, things like placenta previa, where the placenta delivers before the baby, or a breech presentation, where the limbs or the buttocks are part of the presentation instead of the head. And then, of course, labor that's induced by drugs. So drugs or alcohol during pregnancy, smoking during pregnancy, anything like that. And then finally, meconium staining if and when the amniotic sac breaks. These will all indicate to us that the patient is at high risk for neonatal resuscitation, for a neonatal issue to occur after birth. So what can we do to get necessary information from a patient that's having uncontrolled pain from contractions? It's actually it's a very loaded question. If mom is alone, we may just need to get as much information as we can in between contractions and allow her to push and experience those contractions when they occur. We also want to remember that we need to time those so that we understand how close we are to childbirth and delivery. Also, if there are family members or friends on scene, we can ask them. I usually defer to close family members, whether it be the spouse's significant other, or if it is our patient, the pregnant woman's parents, especially mom. Now, I don't want to pigeonhole myself here and get killed in the comments by, oh, you have to ask for mom. I'm just saying, it's more common that the mother will have more information than the father of our pregnant patient. That may not be true. Do what is best for you and your patient as you arrive on scene. But remember, it's almost impossible for you to get anything from a patient while they are screaming because it feels like every muscle in their body is being ripped out with a rake. Moving forward, normal childbirth. Your job as an EMT is not really to deliver the baby, it's really to assist. The mother does all the work. We've known for thousands and thousands and thousands of years that childbirth is something that, not even thousands and thousands, millions of years, that childbirth is a natural process that we are simply making more safe. It used to be very common for mothers to die during childbirth. That was a very common cause of death back in the days before modern medicine. What we do now is, in addition to providing excellent care to both mother and fetus as it is born, we also provide a nearly aseptic procedure area where we can deliver the baby. And this is both in the pre-hospital environment and in the hospital environment. Of course, it is always more clean and sanitary in a hospital. That's just the way that it goes. But as EMTs, we have our obstetrics kit, or our OB kit, that has a lot of these devices that are specifically for aseptic technique. Some of those pieces of equipment would be things like sterile gloves. We don't use our normal gloves on a childbirth call. How about a chuck or chucks, whatever you'd like to call it? That's a sterile work area that you can depend on because it's been wrapped up in this bag with the rest of our childbirth equipment, and so on and so forth. Your role is really to figure out, okay, are we going to have this baby here, or are we going to take him to the hospital? And if we're going to have him here, what can I do to help? Again, the childbirthing aspect of the call, you're going to be doing very little. You'll be manipulating the baby very slightly. You'll obviously be catching them and then assisting with the cutting of the umbilical cord and then starting the transport while we wait for the placenta to deliver. But we're really not doing all that much. This is not a procedure where we're yanking children out of the womb and delivering them proudly and saying, "Ta-da! It's a boy, it's a girl." Okay. Now, what do we do if we see, this looks like it's going to be delivered on scene. The cervix is fully dilated. I can see the top of the baby's head. I can tell that the contractions are very close, and we're going to deliver here. Well, we need to prepare our scene. First, we need to control our scene. This is a great opportunity for us to get ALS, as well as as well as the fire department and possibly law enforcement if we're in a public area. If we're in a home, we don't really need to get law enforcement on scene, but it would be a good opportunity for us to reach out for additional care. Because remember, we are potentially about to have 2 patients. And when I say potentially, I mean we may potentially have 2 critical patients. Childbirth is not something that is without issue. During childbirth, it is not common, but it can happen. The mother can experience a medical emergency that would render her in need of additional care. And then, of course, the baby is the most fragile, so we're concerned about the health of the baby, the fetus. Next, we want to always make sure that we wear our proper PPE. This is going to be a full head-to-toe setup. We're going to look at a gown, boot covers, gloves, and remember, when we're delivering, we're wearing our sterile gloves from our kit, as well as goggles or some type of a face mask, and then some type of a face covering so that we do not expel our own nonsense from our mouth and nose into the patient care area. We want mom on the floor or on some type of a soft surface. And I know that the floor doesn't sound like the softest surface, but that's the best place for us to work. So we may need to have them there. The ambulance stretcher is a little more difficult. It's not big. We don't have stirrups. And for those of you that don't know, stirrups are where the woman would normally place their legs in a hospital setting so that they were able to push off of those and really put in extra effort in every contraction. But we can work them up there, or we can work them on the bed. And the only reason that I don't typically work them on the bed is because it's very soft, it's very clean, and it's about to get very dirty. And I don't know of anyone that has ever encountered childbirth in a bed that left the mattress salvageable. That's usually a wholesale loss. So I like to put them on the floor where I can work them, and then we can clean up the carpet or whatever after. We also need to remove their clothing. Now, this is obviously a very special case. We need to make sure that we are honoring the wishes and requests of the patient and their family. And we also want to assess the need for every article of clothing. If they're wearing jeans and a t-shirt, we need to get the jeans and their underwear off. We can keep the t-shirt on, but remember, after the baby is delivered, we want to encourage mom to hold the baby at the on her chest, because skin to skin contact will help with the very, very early stages of development in the baby, and will encourage it to breathe more effectively, and it can actually help mom too. We also want to encourage mom, if she's willing, to breastfeed as soon as the baby is delivered. And that has to do with both nutrition for the baby, but it also helps with mom's recovery. If mom is breastfeeding, that usually leads to a reduction in bleeding from the vaginal canal and will allow us to more effectively control blood loss from the procedure. Okay? Then we need to position our assistants and our OB kit. And we want our OB kit and our assistant, because our assistant is going to be handing us things. We want to make sure that this is not an area that is trampled over by people walking in and out of the scene. We want it off to the side. And of course, we want to control our scene to make sure that nothing is going on. Also, at this point, we need to send someone out to the ambulance. So you've got a very specific set of instructions. Turn the ambulance on, turn on the heater in the back. This baby is going to be very susceptible to heat loss, and mom is to a certain degree too. So we want to get that temperature up in the back of the ambulance. The only time that we wouldn't want to run that heater as hot as we can is if mom is already starting to show signs and symptoms of hyperthermia, which is rare, but something to consider. So if you're working out in the desert areas, if you're working out in Arizona, Nevada, parts of California, and it's 125 degrees outside, we may not want to go ahead and run that heater just yet. We may just go ahead and leave the doors closed. We also don't want to keep it too cold in those situations, so temperature is definitely something that we're concerned about. On the other hand, if it is very cold, if you're working in a cold area where it's below zero and snowing, that heater is going to be a lifesaver, literally, and we need to make sure that mom and baby are both taken care of for heat loss prior to getting in the back. Now, what you can see here is a typical presentation of our patient as we are preparing for childbirth. This patient has been disrobed, so we've taken her clothes off, and then we've utilized both the chucks, and you can see the chucks in stages 1 and 2, as well as gurney sheets or ambulance or hospital sheets in figures 3 and 4 to cover up some of the more personal areas of the female anatomy. Remember, we always need to be able to see the vaginal opening, so that is going to have to be uncovered. If we're dealing with some sort of a situation where we don't have control of our scene, this may be a good opportunity for us to say, we're going to load the patient on the gurney, we're going to go out to the ambulance, and then we're going to cover our windows so that we can work in peace, so that we don't have a lot of prying eyes. Childbirth is an amazing procedure. It's an amazing phenomenon, but it is not something that we want to necessarily broadcast to the world. So we want to take patient privacy into consideration. Now, what you can see here are the average contents of your everyday obstetrics kit. There are a couple pieces missing, but I do want to focus in on a couple of specific aspects. Number one, bottom right. You can see that there is a white paper material with what looks like gloves. Those are sterile gloves. I'll be putting up a video on the procedure of donning and doffing, specifically on donning surgical gloves in an aseptic manner so that we don't introduce our own contaminants, and that will be available below. Another piece of equipment that you see here is just above the gloves between the bulb, or next to the bulb syringe in the blue, and the scissors, the silver scissors. That tiny little thing, what is that? Well, that's a beanie. We're going to put that on the baby's tiny little head. Some OB kits will also have socks, and one aspect that this kit is missing that every OB kit needs to have is an identification bracelet for mom and for baby. Why is that important? There is nothing indicating who this baby is to the world. It is not uncommon, and I don't want to scare anyone, but it's not uncommon for babies to be switched at birth. It's not a tabloid headline. It truly does happen. And because we are recording every single aspect of this child's entry to the world, their time of birth, we may even be putting down their name if mom tells us what their name is. But we need to identify them. So what we have in our kits, where up here where we work, are individual bracelets, one for mom and one for baby. They're uniquely numbered. Some of them even have QR codes, and they are only going to be replicated once in that kit. That is what helps us keep mom and baby together. There are even some kits and even some of these wristbands that have RFID chips, and they can be used to track where mom and baby go. Why is that important? Mom and baby might not be going to the same place. If the baby is severely depressed, if we have to do some type of neonatal resuscitation, or if mom is sick or depressed and we need to do some type of resuscitation on her, or one of them needs specialized care, they will be separated for a short period of time. And that's a scary proposition. I've always found that the bracelets help assure mom, family, significant other that everything will be as it were when we get to the hospital. The baby is not going to get separated from them. They will see the baby again because we have this unique system to keep track of where they go. And then the rest of the kit is pretty standard. That blue sheet in the middle is known as a Chux, and that's spelled C-H-U-X-S, Chux. And that Chux is an absorbent pad. There's a roll of tape. There's a clear bag that we will put the placenta in. And then we also have all sorts of different sizes of gauze. Now, I did skip over a couple pieces here, like the bulb syringe, the scissors, and then most specifically, those 4 white plastic pieces that are next to the Chux, the sterile gloves, and the tape. Those little pieces of plastic are known as umbilical cord clamps. Those scissors are for one thing and one thing only. They are to cut the umbilical cord. And then finally, the bulb syringe. The bulb syringe is a device that we have seen fall out of favor more recently, but it can be a useful device. We're going to use this for suction. So just in case our patient starts to show that they are that they may have some type of mucosal involvement, they may have a lot of sputum or may have some fluid in their upper airway, their mouth and nose, we can suction this out using a bulb syringe. But it's a very delicate procedure, and we need to be very careful about how we go ahead and utilize it. That's why a lot of systems have done away with it. Now, as we're getting ready, we want to prepare mom for delivery, okay? Regardless of what's going on, if we have a situation where our OB kit is not readily available, we can use other aspects of regular everyday household items to prepare mom. Instead of using Chux, we can use clean sheets and towels. Instead of using umbilical clamps, we can use heavy flat twine or some new shoelaces. And remember, we want this to be as aseptic as possible. We can use a towel or a plastic bag to store the placenta. We can use clean, unused rubber gloves and then some type of eye protection in lieu of our aseptic or sterile gloves and goggles. And then we can always use some kind of a head covering for the baby fashioned out of a towel or some other material. Now, where you need to start thinking about the ethics of all this isn't while you're working, but really if you're off duty. What is your job specifically if you're off duty and you find a woman that is in the stages of delivery? Well, our first obvious aspect of care is to assess mom to make sure that she is in fact, does have an airway, is breathing, and has effective circulation. The next step, call 911. Call for additional backup. That's a guarantee on any of these pregnancy calls. If you and your partner are the only ones on scene for a childbirth, there's something that is significantly wrong. There should have been more people there. It may not be your fault, but ideally, we want additional hands on deck for this call. Now, as we deliver the baby, we need to stay in a position where we are in constant view of the vaginal opening. We also need to prepare our patient to experience significant discomfort. I don't like the way that they wrote it here. Experience discomfort. It is going to be the most painful experience of their life, most likely. So, preparing them by saying this is going to hurt, and they already know. But reminding them once is good. We don't need to keep reminding them, this is really going to hurt, this is really going to hurt. That's not going to provide a whole lot of emotional support. So if you tell your patient once, that's probably enough. And you don't need to remind them if they're already saying this feels like the worst thing in the world. This baby is going to kill me. Get it out of me now. Get it out, get it out, get it out. We need to provide emotional support. If we have additional personnel on scene and the significant other is not there, We may have someone whose sole job is to be their coach, holding their hand, letting mom slowly break their hand. No pun intended. Moms squeeze very hard. And then, of course, reminding them to push when we are dealing with a contraction, and then coaching them as they are in between contractions. You're doing really well. You're doing really well. Wiping the sweat off their forehead, cooling them down a little bit with maybe some lukewarm water around the neck, back of the neck, and maybe just dabbed on the forehead, because mom's going to be sweating. She's going to be working really hard. We also want to try to communicate to the patient what they're doing, and this is a good time for you to practice some positive reinforcement. Mom, you're doing really, really well. You're looking really good. I can almost see the very top of the head. You're doing great. You're doing great. And then further along, fantastic, mom, good job. The head is delivered. We're at the shoulders now. You're doing so good. And then walking them through that. We also want to understand that this process, even though the mom may have gone through it before, is something that can be a little bit scary. So again, that person that's providing emotional support should really be up at mom's head or at their side where they can see them. As for the person that is, for lack of a better word, catching the baby, we want to keep gloved hands at the vaginal opening as the baby's head starts to appear. And specifically, we want hand-head placement. So what does that mean? Well, first and foremost, we want one hand below the vaginal opening, and specifically to prevent for tearing of the perineum or the perineum, we want pressure directly on that patch of skin and flesh that extends between the bottom of the vaginal opening and the rectum. That area is very prone to tearing if there's no pressure that's being pushed on it. Now, we don't need to push very hard. Some light pressure will prevent tearing or will minimize tearing to the most that we can possibly do. If there's tearing, it happens. It's not something that we would prefer to see. We really want to try to prevent that as much as possible, because in addition to being extremely painful, it's also another source for infection and significant blood loss. We also want the second hand right about where the head will be out on the top to prevent it from being expelled rapidly, okay? So above and below, and then again, hand on the perineum, providing slight pressure until the baby begins to appear. If the amniotic sac appears, so if we start to see that fine film, that fine filmy looking membrane as the baby is delivering, we need to use our finger to swipe and then puncture the amniotic sac. Now that's going to cause a fair amount of fluid to come out of the patient from the amniotic sac, so be aware of that. The water that is coming out is absolutely necessary for healthy development, but we want you to know that there's going to be a significant amount of mess from that, okay? Normally that process has already happened, but if the baby's head starts to deliver, then we need to puncture the membrane. After the head delivers, we immediately want to look at the neck to make sure that the umbilical cord is not wrapped around it. Again, that cord being wrapped around the neck, known as nuchal cord, is significantly dangerous to the baby and will cut off oxygenated blood flow to the brain and the rest of the body. Okay? Now, as the baby is coming out, we want to help deliver the shoulders. This is a very easy procedure, and we're just going to use a little bit of pressure. As we're doing this, we want to push the protruding shoulder down and then the other shoulder in the opposite direction. So again, as the first shoulder comes out, we're going to provide a little bit of pressure and push down, and then we'll push the other shoulder up. If the baby is born in a breech position, or if we have some type of pregnancy complication, that may not be the order of events, and in that case, we're going to let the baby deliver as is. But we'll talk about pregnancy complications a little bit and the way that we're changing how we deliver them. Okay. Support the baby during the entire process. And I will make a quick note here. This baby is going to be unbelievably slippery. They're going to be very, very slippery. So we want to be very cautious about the way that we deal with them. It is not uncommon to hear of babies slipping out of the arms of the doctors or nurses. It doesn't happen every day, but it's an embarrassing thing to happen. And you definitely don't want that to happen while you're taking care of your patient. Then we need to assess the airway after we check for that nuchal cord. If we see that the airway is clear, that's fantastic. A great way for us to clear the airway is to vigorously dry the face with one of our towels. Not only will that allow us to clear the mouth and nose, we will also be able to begin the process of getting the baby awake and assessing for its responsiveness. Once the baby is delivered, all of the baby, we're going to note the exact time of birth because that's going to go on their birth certificate. Congratulations. You're just so awesome that you get to be a part of a brand new baby as they enter the world, and you get to note the time that they were born. What a cool opportunity. Also, a totally legitimate reason to make sure that your watch is always set to the right time. Moving forward. So as you can see here, the provider has placed a gloved hand above and below where the head will deliver. And you can also see that they are applying pressure to the perineum using a gloved hand and what appears to be a dressing. As the baby appears, they'll begin to rotate. And as they rotate, you'll see the shoulders. By applying gentle pressure to the first shoulder coming out down, and the next shoulder that's coming out in the opposite direction going up, we'll be able to deliver the shoulders without causing there to be too much pressure on the cervix, and we will lessen the likelihood of tearing of the ring that makes up the cervix or any of the other soft tissue in the vaginal opening. As you can see here, the baby is delivering. After the shoulders deliver, that baby just pops right out. Just make sure that you don't palm them like a football, okay? And then the baby is fully delivered. And you can see that the umbilical cord is still attached. The umbilical cord is finally attached at the placenta. The placenta is attached to the wall of the uterus, and that will all deliver later. Okay? Now, what are we dealing with? We now have two patients. We have our mom, and now we have our neonate. Now, a neonate begins as soon as they are officially born, their time of birth, when they deliver from the vaginal cavity. And they will stay in that position of being a neonate until they're about 28 to 30 days old, depending on who you talk to. Okay? Protocol usually calls for noting ease of breathing, their heart rate, crying, movement, and skin color. And we use something known as APGAR. APGAR is based on appearance, pulse, grimace, activity, and respiratory effort. And APGAR is usually found in our PCRs as a drop-down tool that we can use. And we're going to assess this on a pretty regular basis. It's usually 1 minute, 2 minutes, 5 minutes, or some combination therein, depending on where you work. But that's usually reserved for the paramedics. As EMTs, what can we look for? Well, look for activity right off the bat. We want to look for activity because their appearance and pulse will be usually based off of that. If the patient has no activity, if they are not moving right after they're born, the very first thing that we can do is stimulate. How do we stimulate the baby? Well, we're not going to do what they did back in the day. We don't hang them by their ankles and slap their butt. No, now we can flick the bottom of their foot or rub the bottom of their foot. We can also massage their back. And another great way to increase the amount of activity in our neonatal patient is by vigorously drying them with the towels that we have in our kit. They're going to be covered in a very fine white film, which is a totally normal aspect of patient care. That's actually that's a material that's supposed to be around the baby, and it actually is it's very moisturizing, so that's not a bad thing to have, but we want to get as much of that material off with the towel as possible. That in itself should cause our baby patient to perk up and start crying, okay? As we're doing that, we will also want to prioritize keeping the baby warm. Heat retention is huge. So we'll dry the baby, discard any of the wet blankets, and then wrap them in a dry blanket. We can also use an infant swaddler, but I would definitely shy away from possibly using a space blanket unless it's included in your OB kit. The reason why is because these babies will generate an incredible amount of heat after they start moving around because their metabolism is starting and they're starting to develop. If you put them in a space blanket, it would be almost akin to cooking them, and it's not uncommon to hear about stories of babies or very young infants that are placed in space blankets or emergency blankets that suffer anywhere from first or second to sometimes even third-degree burns because the amount of heat that they generate is being radiated and cooked back into them. We also want to cover the head, and that's why so many of these OB kits now, in addition to having all these different dressings and specific tools, they also include a head covering or a hat, and many of them have tiny little socks too. Now, we also want to encourage the baby to move around. So we really want to understand that while we're drying the baby, we don't need to be gentle as if they are still sleeping and we're trying not to wake them up, but we want to make sure that we're not going into that realm of drying too aggressively. But wiping them off at a pretty rapid pace should wake them up. And then we get to the umbilical cord. When does the umbilical cord need to be cut? Well, there are certain specific circumstances where it needs to happen. Now, if the cord is wrapped around the baby's neck, we can alleviate that situation by slipping a finger or two underneath one of the wraps on the umbilical cord and then slipping it over their head. If it's so tight that that's impossible, we need to find 2 locations to clamp. We'll clamp in either location, clamp, and then cut in the middle. If the umbilical cord is in a way interrupting our resuscitation effort, it may need to be clamped and cut. Or if the umbilical cord interferes with the urgent need for transport of the mother or baby, or if your protocol requires that it is immediately cut, then we'll do that. Locally, our guidelines are to wait until the umbilical cord stops pulsating, and at that point, we can infer that the baby is no longer dependent on that oxygenated blood flow and that transfer of gases through the umbilical cord from mother to baby. So we can go ahead and clamp it in 2 places and then cut it in the middle. Now, the steps of this are very easy, and I'm going to throw in an additional step, okay? Number 1, keep your infant warm. And number 2, always use sterile clamps or umbilical tape. And most of our kits include sterile clamps only. 1 clamp should be about 10 inches from the baby. So you can go ahead and measure that out, but do your best and try to eyeball it. The second clamp needs to be about 7 inches from the baby. Again, eyeball it. After those are both put in place, we want to involve a family member or a significant other or whomever to cut the cord. Now, this is a very big process. It's a very big step. If the family members can't be reliably trusted with that procedure, we may need to do it ourselves, but I always like to offer. And I always like to make sure that the significant other is the one that gets a first crack at it, because this is their baby too. You know, they either they helped conceive the baby, or they are, you know, married or partnered with this individual. So we want to give them an opportunity to be a part of that process. They didn't get to catch, but now they get to cut and start that life together. It's a very symbolic moment, and it's important. So don't be the glory hound that says, "Oh, I'll cut the umbilical cord." Give that up to the family members. They've been taking care and nurturing this baby too. Not to the extent of the mother, but they've been there as well. So give them that opportunity. We also want to make sure that we take care when we move the baby so that there's no trauma brought to the clamp cord. And remember, we're cutting this fairly long, so when the baby gets to the hospital, they can have the umbilical cord removed surgically, and then that process will make sure that there's very little to no scarring. And if you've ever seen someone with a protruding umbilicus or a protruding belly button, that's usually a pretty decent indicator that the cord was cut in an inappropriate manner. It can also be an indicator of a hernia, so I want to put that out there too, but we don't cut that close. We're still 7 inches out from the baby, so there's still going to be a fair amount of cord that is still detached, okay? And then we want to place the baby on the mother's abdomen after the birth process and encourage skin-to-skin contact. Remember that, skin-to-skin contact, okay? So what you can see here is that the clamps have been placed, and now the provider is bringing in the scissors to cut the cord. Now, we've already noted why it's so important to stimulate the baby, but I want to reevaluate that. The baby needs to be stimulated so that we can get them to do normal things on their own, like breathe. Breathing is going to be a major part of their developmental cycle. And if we don't get them started right away, that can indicate that the baby is depressed. And I don't mean depressed as in, oh man, I was just born into coronavirus or whatever the case may be. No, I mean they are depressed as in they are not breathing. They do not have a pulse rate that's acceptable. They are not pinking up. They're not showing any color. That's a big problem, okay? So here's where we get to neonatal resuscitation. As we are assessing our baby, we need to make sure that they're breathing, and we need to assess essentially their ABCs, respirations, heart rate, and then also muscle tone. If their breathing is shallow, slow, gasping, or absent, we're going to provide positive pressure ventilation at a rate of 40 to 60 per minute. So you'll be providing that at a rate of anywhere from a breath every second to a breath every 4 seconds. Somewhere in that range is usually what we're looking for. Also, we need to check their heart rate. If you remember back to CPR, we know that we can check for a central arterial pulse on the brachial of a toddler. On these neonates, we may need to go for a more central artery. So we may need to go for the femoral, or we may be able to find it off of the brachial. However, we will not assess for the pulse off of their carotid artery. That's unacceptable on these infants and neonatal patients. So not okay. Don't put your hands on their neck at all. If their heart rate is less than 100 beats per minute, we want to provide artificial ventilations, but we'll hold off on chest compressions. If the heart rate is less than 60 beats per minute, we will initiate chest compressions at a rate of 100 to 120 per minute. If the respirations are adequate and the pulse is greater than 100 beats per minute, we're going to reassess the airway. Okay? Moving forward. In neonatal resuscitation, we have a descending order of importance in terms of least invasive to most invasive when it comes to neonatal resuscitation. Basic neonatal resuscitation starts with drying, warming, positioning, suction, as well as tactile stimulation. Okay? The next thing that we can provide is oxygen, and these are not going to be good candidates for some type of a mask or nasal cannula. We can provide this through blow-by oxygen. After that, we go further down the line to bag valve mask ventilation. And again, if we're going to be doing some type of ventilatory support, we're going to be bagging at a rate of about 1 every second to 1 every other second. Moving forward, we go to chest compressions. And then we get into advanced care, which is intubation and medications. Now, where I teach and where we all work, intubation is not something that we provide for pediatrics, infants, and neonates out in the field as ALS providers, but we do provide medications. And if we get to this point, the baby is severely depressed and we are doing a full workup on them, a full code blue, a full code on them, whatever you want to call it. They are in cardiac arrest. So typically we can do other things to stimulate them to get their heart rate up, to get their breathing rate up. And it's not very common that we have to do all of this, but when we do get into some of these things, we go through this upside down triangle because we want to go from least invasive to most invasive. And this is a good opportunity for us to talk about neonatal resuscitation. It's important to remember our resuscitation or our compression to ventilation ratio will be 3 to 1. 3 chest compressions and then 1 breath. 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe. So on and so forth until that baby pinks up and they start looking like they're a real gosh darn baby. Now, neonatal resuscitation is difficult in a lot of different cases, and they're very small. We have to use specialized equipment. Sometimes they're so small we can only get a single finger on their chest that, they're so tiny that it's not even appropriate for us to use two-handed techniques. And then there's the emotional aspect. It's never fun or easy to see a tiny baby that is in cardiac arrest or any kind of arrest. So it's important to understand that we need to care for the baby first, mom second, and then after the call is over, us. Well, the first steps in a neonatal resuscitation are going to be vigorous drying of the patient, as we discussed before, following that upside down triangle. And then understanding what cyanosis looks like in infants and neonates is important as well. Central cyanosis will affect areas like the chest, the abdomen, parts of the neck and face, and then possibly in the pelvic region. Systemic cyanosis, on the other hand, is going to be cyanosis all over in all those areas plus all the extremities. If our patient is cyanotic only in the central areas, there is a possibility that they are already breathing on their own, but their body is repurposing that oxygen in an odd way. It doesn't usually happen in that format. What normally happens is that we'll start to see everything pink up, with the very last being the extremities, but it depends on how your baby is presenting. And then finally, artificial ventilation is required when we find a heart rate that's under 100 beats per minute, or in a respiratory rate that's under 60. Okay. Moving forward to care after delivery. Mom is at serious risk for bleeding, infection, and embolus or emboli. So we need to make sure that we take care of mom too. We want to focus on bleeding control first, and comfort, as well as getting mom to do skin-to-skin contact, having mom provide some type of breastfeeding that will help with the vaginal bleeding. And then at the very end, we're going to be thinking about the placenta delivering. That'll be pretty obvious because it doesn't just deliver itself. There are still going to be contractions involved, so mom will know about when that happens. But remember, we don't delay transport to wait for the placenta to deliver. The placenta is also commonly known as afterbirth. So the placenta will deliver with the umbilical cord, pieces of the amniotic sac and its membranes, and then tissues that line the uterus. We want to save as much of that as possible because that'll be utilized by the hospital staff to determine the overall health of the baby, and they can also extract certain things that can be used if the baby becomes sick or injured in the next couple of months. There are also, and this is important to note, the placenta also has very special significance in specific cultures. Specific cultures mandate that members of the family actually eat the placenta after delivery, and so we want to be respectful of that, but remember that it is a medical call first, so we want to have the placenta inspected first, all right? Placenta delivery starts with labor pains. It can take more than 30 minutes, and then again, we're not going to wait on scene for the delivery of the placenta. Now, how can we control bleeding in our new mother? Well, we can place sanitary napkins over the vaginal opening, but we don't want to pack anything inside. Now, for guys, this is especially important to understand. Vaginal bleeding in cases where we're not dealing with pregnancy, if we're dealing with menstruation, can be controlled by a sanitary napkin or a sanitary pad, or it can be controlled through a device known as a tampon. We're not going to put anything into the vagina because it's very tender, it's very fragile, and we could cause significant soft tissue damage. So we want to keep everything outside of the vaginal opening and just collect outside. We can also have the mom lower their legs and keep them together but not squeeze them together. And then we can start helping with the bleeding by massaging the fundus, which is located below the average belt line, so it's right around the pubis, and we can go ahead and we can start massaging that area as well. And it depends anatomically where that lies on the mother as well, the fundus. We also want to encourage mom to begin nursing the baby and, again, encourage skin-to-skin contact to maintain heat. We also want to make sure that we're taking vital signs on a frequent basis. This patient isn't necessarily a critical patient, but they did just give birth. So if you feel like it's within your best interest to take them every 5 minutes, go right ahead. If the patient is looking very comfortable, if baby is progressing well, if mom is beginning to stop bleeding, we might want to consider taking them every 15 minutes, especially on some of those longer transports. Also, remember that this is a great opportunity for you to express and exercise that empathy muscle that we just don't get to use that much. We can give mom little things like maybe some ice chips if she's hot, or tell her that she's done an amazing job, and compliment her on all the work that she did. Again, EMTs don't deliver babies. We're simply there to observe and catch. The mom has done all the work. This is totally a fine time for you to say, Hey, you did great. Good job. We can also wipe their face and hands with a damp washcloth. And then, of course, we want to try to immediately replace blood-soaked sheets and blankets and try to get them bagged up so that they're not just laying on the floor, the carpet, or the bed. Also, we want to think about some of these aspects of care. If you're taking care of a mother, especially if they don't have family or their significant other around, you are their closest person that they can talk to about what's going on. So be a listening ear. Be the kind of person that they can talk to. Also, we need to understand what's considered to be usual for blood loss. It's difficult for us to quantify what we're looking for out in the field because quantification or counting how much blood loss has occurred is it's a very difficult thing to do. Um, I always say that if the patient is not complaining of dizziness or nauseousness or actively vomiting, if the patient is mentating appropriately, they are times 4. And if the patient isn't starting to show any signs of cyanosis in their extremities, then blood loss has been staved. It's okay. If they're starting to show any of those signs, then blood loss is probably at a very significant stage, and we need to aggressively control it. Okay. Childbirth complications. This is where we get into the problems, and this is where we get into a lot of the scenarios that you tend to see in the National Registry as well as other applications for testing. So it's important to understand that this is not a complete list of all the possible childbirth complications. These are just the ones that we would like for you to be most aware of. First and foremost, cord around the neck, also known as nuchal cord. Cord around the neck, as we've already discussed, is a significant problem because that will cause there to be a lack of blood flow to the brain, and we're cutting off blood flow to the rest of the body because it is occurring from the umbilical cord. We need to rectify that right away, and if we find that, we need to go ahead, clamp, and cut. Then we have the unbroken amniotic sac. If the baby delivers and the amniotic sac is present, it may not in and of itself be an emergency. It may just be that there was not significant enough contraction to cause it to break. But if the baby delivers and begins to breathe on its own and the amniotic sac has not been broken, they are now breathing in all of that amniotic fluid, which is absolutely bad. And then, of course, we've got our infants that need encouragement to breathe. These are the ones that don't perk up right away. They don't start breathing, crying on their own, and we need to work with them a little bit, okay? Moving forward, we have breech presentation. It's the most common type of abnormal delivery, but breech presentation has so many different permutations, so many different types, that it's important to understand we're talking about very specific types of breech presentation here. Breech presentation is known as buttocks or legs first delivery. There's a high risk of trauma to the baby, and we will probably see meconium staining. There is also the breech presentation where limbs, whether singular or plural, present instead of the head. It's usually a foot, or it can be a hand or 2 hands like they're doing the Superman dive. Whatever the case may be, if a baby is in breech presentation, it typically means that the baby is in distress. Now, this is where our local protocols where I teach break away pretty significantly from the National Registry standards. National Registry standards state that if a baby is in any breech position, whether it be limbs, buttocks, feet, whatever the case may be, they may not be delivered in the hospital. We want to encourage the mom not to push during contractions, and we need to emphasize rapid transport to the hospital. If we had code 3.5, we would do it. In our local area, and this is specifically for my students, it is acceptable using your local accreditation to deliver some types of breech presentation, and that would be buttocks or a single arm or leg. Here's how you do that. When the baby is born in a breech position, you will allow the baby to present in its normal fashion. However, we will not put our hands on the baby until the airway appears. Why? Once we put our hands on the baby, an arm, a leg, the buttocks, whatever the case may be, that could be just enough stimulation to cause the baby to cry and breathe. If the baby is still in the vaginal opening, if they're still in the birth canal, they are not breathing oxygen. They are not in an environment where they can breathe air. They will aspirate and suffocate in that space. So we will allow the baby to deliver until we see the mouth and nose. The mouth and nose needs to present, and then we're going to grab that baby and we're going to start drying it off right away. And again, because a breech presentation usually indicates that the baby is in distress, then we will anticipate that that baby will need resuscitation attempts. Okay, so these are a couple pictures of different types of limb presentation. And as I said before, this baby's in distress. It is moving around so much that it's rotated either a complete 180 degrees or 90 degrees, whatever the case may be, because their head is not what's presenting first. So this is a baby in distress, and mom will probably be able to tell. But if you go down to do your inspection of the vaginal opening and you see that it's not the top of the head, instead you see a hand or a foot or the buttocks that are presenting, this is a problem, and we need to follow our local protocols. So again, National Registry cannot deliver breech, cannot help at all. Tell mom not to push, rapidly transport to the hospital, advise that you're bringing in a breech patient. Locally here, where I teach, and my students all know where that is, we're going to go ahead and we can deliver breech presentation if it's buttocks or a single arm or leg, with the exception that we do not touch the baby until the airway delivers. Moving forward, prolapsed umbilical cord. Now, the umbilical cord is a vital aspect of patient nutrition and patient sustainability and viability. So typically, the way that the baby presents is that the umbilical cord is well behind it, and the first thing that comes out is the head, followed by the shoulders and the rest of the body. And then we start to see the majority of the umbilical cord. Not all of it, because remember, that umbilical cord is still attached to the placenta, which in itself is attached to the wall of the uterus. When the umbilical cord becomes the first thing presenting, we have a possibility for oxygen supply being totally interrupted to the baby. And this is a life-threatening situation. So if we have a prolapsed umbilical cord, or if we have any type of involvement of the umbilical cord, we need to identify where it is and then rapidly deliver the baby. We need to rapidly identify where the baby is and then transport. Now, here locally, we can't deliver a baby with a prolapsed umbilical cord. We need to rapidly transport that patient, but this is also a good opportunity for us to call in to our base hospital or our receiving hospital to get further instructions, or have ALS run the call, because at this point they may indicate that we want to cut the umbilical cord and really encourage mom to rapidly deliver. So it depends on the case, but as EMTs, we're not going to do anything with that unless it's very obvious that it's wrapped around their neck. But just having the cord present first, not a delivery situation. Okay, so elevate the hips, keep the baby's head away from the cord, don't push it back in. Wrap the cord in a sterile, moist towel. So this is a good opportunity for you to utilize some of those pieces of equipment from the OB kit. And then we also want to transport mom to the hospital, and we may want to place our hand in front of the vaginal opening to keep the baby from forcibly delivering. Okay, so super important that we understand all that. Multiple births. This is where the call becomes more difficult, not because the birth is going to necessarily be complicated, but because we have multiple babies coming off. Okay, these multiple babies are still using the same cord, they're still using the same placenta. So you have to understand that these babies need to be delivered in rapid order, and that as they are delivered, we're going to clamp the cord of the first baby and then assist with the second and third and so on and so forth. Okay, so same thing as before. Keep babies and mother warm, and then call in for backup, because if something goes haywire, if something goes sideways, we may need to prioritize one of these patients to go to the hospital in another unit. Okay, premature births. If the baby is born prior to their due date, they're considered premature, and mom should know probably to the hour when she's anticipating to have the baby. I joked. We know that the mom is anticipating the day that she's going to have the baby, but she doesn't know if it's going to happen morning, noon, or night. We want to keep the baby warm if they are born premature, and then obviously very aggressively attack their airway, breathing, and circulation. So look for those ABCs and expect them to not be as favorable as what we would expect to see in our patients that were full term. We also need to look for things like bleeding in the umbilical cord, contamination, especially from meconium staining, and we want to call ahead to the emergency department to alert them to the premature birth. Now, this is an important thing to talk about here. If we're dealing with a pregnant patient and they're going to the hospital, if they're beyond 20 weeks, they may not go to the emergency department. They may just go straight up to labor and delivery. Labor and delivery actually doubles as kind of a pregnant patient's emergency department if they're dealing with pregnancy-related emergencies, which pretty much every emergency when you're pregnant is a pregnancy-related emergency. There obviously are going to be exceptions to the rule, but if our patient is pregnant, we will assume this is pregnancy-related. There could be relation of the baby to this. We got to take them to labor and delivery. So call ahead, let them know that you're coming in, and let them know really what you have going on. As we've talked about before, meconium staining can be that greenish or brownish yellow color that is in the amniotic fluid. This is waste material. This waste material is very dangerous to the baby and to the mother, and it indicates a couple of things. A, that baby is in distress, and B, they are at prime risk for an infection. We need to suction the mouth and the nose using our bulb syringe, maintain their airway, and then provide any ventilations or chest compressions as needed. And we also want to transport this patient as soon as possible. But meconium staining is a positive finding. And as I've said before, just so we're all clear, a positive finding is not something that is necessarily good for a patient. It's a checkbox that we're looking to say, did we find this or not? Meconium staining, that's a positive finding. That is not going to be good for our patient, either the mom or the baby. We need to prioritize getting them cleaned up, having the baby's airway suction, supporting mom, and then doing any kind of resuscitative work that needs to be done. Now, why is it important to have another person that observes you as the mother is going through childbirth? I think that it's important because it can put a second set of eyes on what's going on. They may see something that we are not focusing on. And then, of course, it gives us an opportunity for them to act as a relay or as a bit of a coach and a spectator, someone that can say, you're doing really good, the baby's halfway, good job, good job. But they can also look at what we're doing and remind us, oh, hey, we need to do this, that, and the other before we go any further. And finally, we get to our emergencies during pregnancy. Emergencies in pregnancy include, but are certainly not limited to, the following. Excessive pre-birth bleeding. It is not uncommon for the mother to begin bleeding prior to childbirth. Ectopic pregnancies, where the egg is fertilized outside of the fallopian tube. Seizures, which, as we've discussed before, seizures are not a sign, they are not an individual concern, they are usually an underlying symptom of something else. Miscarriage and abortion, trauma, stillbirths, and then, of course, the call that none of us want, cardiac arrest of a pregnant woman. So let's talk about these. Excessive pre-birth bleeding. Unusually profuse bleeding may indicate that the baby is in distress, but really our biggest concern is mom, because mom is providing that blood to the baby, and if they start to lose that, the body may reprioritize that blood flow back to mom. Abdominal pain may or may not be present, so don't wait for that. If you see bleeding, then there it is. That's all that you need to know. We need to immediately assess for the signs of shock and treat with high concentrated oxygen, as well as prioritization of high-speed transport. We may need to place a sanitary napkin over the vagina, and we also want to save all tissue that is passed. Why do we want to save that tissue, Eric? Don't worry, I'll tell you, nobody. The reason we want to save that tissue is because that could be an indicator that the baby has not survived, or it may indicate that there is some type of fetal distress that would indicate an emergency C-section or an emergency delivery of that baby upon arrival at the hospital. Remember, we don't just provide medical care outside of the hospital. We're also acting as the eyes and ears, the trained eyes and ears that the doctors depend on when we deliver our patient to the hospital. So it's equal parts detective as it is equal parts doctor and emotional coach and so many other things. We wear a lot of hats out in the pre-hospital area. Ectopic pregnancy, usually indicated by acute abdominal pain that is referred to the shoulder, vaginal bleeding, low blood pressure, possibly a rapid and weak pulse, or an absent menstrual period. If our patient is working on getting pregnant and they are experiencing any of these pains, or if we have a female patient that's experiencing any number of these considerations, we will go ahead and treat what we can see and understand, transport them to the hospital, and then let them make the determination if it's an ectopic pregnancy or not. It is not wise or advised, I should say, for us to go around to every patient, every female patient complaining of acute abdominal pain and saying, well, it's probably an ectopic pregnancy. Yikes, do not do that. That's what crazy people do. That's what unemployed people did. Don't do that. It's just something to think about in the back of your head, okay? Moving forward to seizures. Again, seizures are not the problem. They are an underlying symptom of what's really causing the problem. It could be preeclampsia. It could be elevated blood pressure. It could be excessive weight gain. It could be due to, or it could be made obvious by excessive swelling to the face, ankles, hands, and feet. And we also may find that the patient is showing signs of altered mental status, headache, or other unusual neurologic findings. Now, it is something to understand. We really want to talk about one thing here, which is preeclampsia. Now, preeclampsia in and of itself is usually indicated by unusually high blood pressure after we hit that 20-week mark. Now, preeclampsia is something that can indicate fetal distress. It could also indicate that the mother is in distress or has some type of an underlying symptom or condition that would lead to a more complicated pregnancy or to some kind of an issue in childbirth. So it's super important to remember that these marked numbers, if we start to see a marked increase of their blood pressure in a pregnant patient, we need to be concerned about not only preeclampsia, but also possible impending seizure. Okay, just something to think about. And remember, seizure treatment for pregnant patients is still the same. When we talk about miscarriage and abortion, we need to understand that these are two terms that mean the same thing. Miscarriage and an abortion are the same thing. Miscarriage being a more soft term, a term that is more beneficial for when we're talking to the family or when we're talking to patients, whereas abortion has quite a stigma attached to the word. But the actual medical term for the termination of a pregnancy for whatever reason, whether it be spontaneous or induced, is an abortion. And that's why when we have a patient that is miscarried, the medical terminology is spontaneous abortion. So some of the signs and symptoms of miscarriage and abortion, miscarriage/abortion, I should say, are cramping, abdominal pains, bleeding that ranges from moderate to severe, and then, of course, the discharge of tissue and blood from the vagina, meaning that that is potentially or most likely fetal tissue that's being expelled from the uterus and from the vaginal canal. Miscarriage and abortion are difficult to deal with. It's obviously a very sad time for the mother, especially if it is not something that is planned. And we respond to all different types of miscarriage, abortion calls, whether it be the after effects of a medically induced abortion, where the mother is bleeding profusely and continuing to discharge tissue and blood, or it could be a spontaneous event that's triggered by trauma or illness or just a simple inviability or non-viability of the actual fetus. But regardless of what the case is, we need to make sure that we are providing emotional support to both the mother and the family members that are there and be very understanding of what's going on. This is also a very private time, so we want to make sure that we are understanding the somber note of what's going on in the call and making sure that we are taking into consideration what has just occurred. So giving them the appropriate space in which to process and grieve. Moving forward. As we see trauma in pregnancy, we need to understand a couple of key components of pregnant women versus non-pregnant women and the way that they're physiologically different. Pregnant patients will have a pulse rate 10 to 15 beats faster than non-pregnant women, and because of an increased volume of blood in their body, may be able to lose up to 30 to 35% of their blood loss total before we start to see signs and symptoms of hypovolemic loss. So that's very important. We also want to focus specifically on the abdomen because, of course, that's where the baby is located. We want to ask if the patient has received any blows to the abdomen. And some other things that we may want to ask is, do you feel that the baby is responding normally? Are they kicking the way that they normally do? Pregnant women, much like individuals that have an extensive medical history or a very specific set of medical complications or equipment, they know everything about it. So ask the patient how the baby is responding, and they may be able to give you a better indication of how that baby is responding to the trauma that it was just involved in. Now, stillbirth is obviously another case where there's significant emotional attachment. We need to be very cognizant of the situation that occurred, but we also want to take into consideration survivability. If it's obvious that the baby has died sometime before birth because of decay of body tissue, if there's an extremely pungent, foul smell on delivery, if it's very obvious that the tissue is in decay, there's no purpose in us doing resuscitation, but we do want to provide full resuscitation measures to babies that are not in that state. And most babies will be in a state of not decay. Again, mothers are getting regular checkups by their doctors, and it takes a relatively significant period of time before that decay really sets in. So it would probably be many, many hours after death of the fetus in utero before it would start to decay. So just something to think about there. We want to make sure that we're providing full life support to this baby, and if the baby died, then mom might be in distress as well. So we may need to provide some type of basic life support to her. But really, the more obvious aspect of care that we need to try to focus on is emotional support and understanding. One thing that I do want to mention, it's not uncommon for babies after they've been stillborn for the parents to want to hold the baby even though the baby is passed. It is an important part of the grieving process, and we need to really allow them to have that moment. It's okay to let them hold their own baby even though it's a stillbirth. It's just not a time for us to say, no, we're doing this, we're doing that. If we have ceased resuscitative attempts, if we're no longer doing chest compressions, we're no longer providing ventilatory support, or we never began doing any of that, it's a good time to let mom and dad, or mom and whomever their spouse or family members are, allow them time to hold the baby and grieve, because it's a very sad time for them. Now, when we deal with cardiac arrest of the mother, of the pregnant woman, we are really trying to focus on a chance to save the unborn child, but we would prefer to save both. So to perform CPR on a pregnant woman, we need to do something really quick. So first, we need to displace the uterus by moving it down and to the left if they're more than 20 weeks pregnant. And we'll also position our hands 1 to 2 inches higher on the sternum because of the shift of the heart due to the uterine displacement that's occurring. We'll continue CPR until a C-section can be performed, until we're relieved in the emergency department, or, and this is of course what we would like to see, the mother is able to achieve ROSC. We can get return of spontaneous circulation in the mother. However, once that patient is in cardiac arrest, we are going to have a very high suspicion that they will return to a state of arrest. So we need to keep all of our tools and equipment out. defib pads on the chest, suction available, bag valve mask attached to oxygen, and us monitoring their vital signs like a hawk. This is our final section, and we're going to be talking about gynecological emergencies. Now, as I said before, we are going to be talking about some violent aspects of these emergencies, including sexual assault. So if you are a bit more sensitive to those things, which totally understandable, I would advise that you come back after these next few slides are done. So here we go. Vaginal bleeding. We don't want to put this off as not something that's important. It's definitely a potentially life-threatening situation, and we want to look for things like associated abdominal pain and the signs and symptoms of hypovolemic shock, especially if they're going into a state of decompensated shock. Also, trauma to external genitalia. We want to look at the scene itself, observe for mechanisms of injury, and then, of course, treat any signs or symptoms of blood loss and shock, and then consider additional internal injuries. Now, just like we've said before, trauma to external genitalia is very often at the heart of a crime scene. So we may want to begin the process of preserving evidence as much as possible, as well as introducing law enforcement to the scene so that we can allow them to begin the process of their investigation in case this was a crime. Now, sexual assault is 100% of the time a crime. So this is a crime scene. We need to treat any immediate life threats and try to avoid disturbing any potential criminal evidence. And that can be anything from clothing that the patient was wearing, any kind of fluids that are found on or around the patient, and the general overlay of the scene. This is where we want law enforcement on scene immediately. We want to examine the genitals only if severe bleeding is present. If we don't see that there's any severe bleeding, we will leave it as is. We don't want to touch it at all. And we want to discourage our patient from bathing, using the bathroom to void, whether it be defecation or urination, and absolutely not allowing them to clean any of the wounds, because that is all considered evidence. We also need to make sure that we fulfill our mandated reporting requirements, whatever our state, agency, or company says is appropriate, and then obviously comply with law enforcement requests as much as we possibly can to preserve evidence so that they can build their case. Now, as you arrive to a crime scene, you should keep a couple things in the back of your head. How does everything look? Is it appropriate for me to begin taking pictures? Do I have someone that can take pictures while I'm performing my patient assessment or applying patient care? Is there anything that's here that would indicate to me that there's still a dangerous element on scene? Do I see anybody that appears to be trying to flee the scene? Also, do I have any indication that this is something that is a load and go scenario where the patient is in immediate danger and we need to do something to allow them to get to a safer place, so on and so forth. Moving forward, we are finally at the chapter review. So let's do this pretty quickly. We're coming up on an hour and 50 minutes, and I'd like to cut before we get to 2. So here we go. Although birth is a natural process that usually takes place without complications, the involvement of EMS usually indicates that something unusual has happened. Perhaps they weren't able to get to the hospital fast enough, the childbirth procedure began, or the process of birthing has begun outside of their window of expected delivery. They're early, they're late, or they were not able to get to the hospital on time. The EMT's role at a birth is generally to provide reassurance and assist the mother in the delivery of the baby. And remember, the mother is doing the majority of the work. We are simply there to help. During the normal delivery, the EMT will evaluate the mother to determine if there should be immediate transport or if birth is imminent and will be done on scene. If a birth is to take place at the scene, we need to make sure that our equipment and the scene is ready, we have appropriate resources on hand, and we are prepared for any resuscitation of either the mother or the baby. Complications of a delivery are a true emergency. An EMT must be prepared to initiate rapid transport in the case of breech presentation, prolapsed umbilical cord, limb presentation, premature birth, or meconium staining of the amniotic fluid. And remember, local policies, local agencies will say things that are different. Where I teach, it is acceptable for a BLS provider, an EMT, to deliver a baby with a simple breech, an arm, a leg, or the buttocks, and do that on scene as if it is a normal child delivery, with the exception that we do not touch the patient until the airway has delivered. There may also be pre-delivery emergencies or emergencies associated with pregnancy, such as excessive bleeding, ectopic pregnancy, seizures, abortion, or some other trauma to the mother. and that the EMT must be prepared to treat all of those as they arrive on scene. Stillbirth, death of mother, and sexual assault are all very difficult emergencies for the EMT, and emotional care for these issues may be as important as medical care. This doesn't just stop at the end of our care of our patient. This also continues after the call is over. We've done a really, really bad job of controlling our emotional response to the way that we deal with calls and the way that we see things out in the field up until recently. And now, more than ever, we're seeing that EMTs are reaching out for emotional support after running difficult calls. We've done a very lackluster job of setting up these different agencies and these different groups that help EMTs, paramedics, firefighters, police officers, you name it, deal with stress, but we are getting better. So the very first thing that you can do is have that internal conversation with yourself that says, I'm not okay, and I do need to see someone, and I do want to talk to someone about it. It shouldn't put you in any fear for your job, and it certainly should not put you in fear of going out to continue doing your job, because having a bad call, having a bad day, and truly having an emotional response to the job is part of the job. Remember, female reproductive organs present new anatomy and specific potential emergencies. EMTs should recognize the different anatomy and should be prepared to address reproductive emergencies overall. A growing fetus creates massive change to the mother's body. All systems will undergo major alterations, and they will show major physiologic changes in our patient's overall health and safety. Assessment of the woman in labor is designed to predict imminent delivery and recognize likely resuscitation. The urge to push and crowning indicate imminent delivery. Transport typically should be deferred for a home delivery, and we should allow our EMTs and paramedics to use their judgment as to what is an acceptable time for us to stay in play versus load and go. Lack of prenatal care, premature labor, multiple gestation, and underlying conditions indicate a likelihood of neonatal resuscitation and should indicate that we have that equipment available as the child is being born. Childbirth requires a high level of personal protective equipment and should be donned immediately after we've determined that childbirth is imminent and will be delivered on scene or en route to the hospital. Remember, the most important aspect of care for a neonate is keeping the baby warm. Resuscitation may be indicated by assessing breathing and heart rate. After delivery, there are two patients to care for, the infant and the mother, with the infant being the most critical and the mother following in second. Finally, EMTs should be familiar with the pathophysiology and emergency treatment of the various complications of childbirth. And also, finally, care of sexual assault patients must include medical, legal, and psychological considerations. This concludes our PowerPoint presentation of Chapter 32 from Limmer's Emergency Care book. I'm Eric Johnson, aka the Band-Aid Man OC. Thank you very much for stopping by. Be sure to hit that like and subscribe button if you enjoyed this content. Comment down below if you have any questions, comments, concerns, thoughts, or ideas, and continue consuming all this content as it is the most complete and available version of EMS education this side of your textbook. Thank you very much. Have a wonderful day. Goodbye.